invited each of the HIEs that support the Kansas City area and Kansas and Missouri. There's 3 of them. And we have Angela Bass, who's director of MHC, Missouri Health Connect, which is the Missouri Health Information Exchange. And Angie, you want to wave or stand up? Next is Mike Dittemore. He's with LACIE, the Lewis and Clark Health Information Exchange. Michelle McGuire with KHIN, the Kansas Health Information Network. And then Marc Willard's here as well to be on the panel for HIE, since that's basically his expertise, and again with Certify and what he does. So each of the HIEs are going to come up and they have a couple of slides just to talk about who they are and what they are. A lot of people here are already aware of it. Angie, if you want to go first. No, wrong one. I thought I had you up. Guess I don't. There you are.
All right, well, thanks for having me here today. It's a pleasure to be here and be in the Kansas City area. Again, my name is Angie Bass. I'm the Director of Business Development for the Missouri Health Connection. That's it. Which button do I hit? Oh, maybe. There we go. So the Missouri Health Connection is the state-designated health information exchange. We were founded in 2010 as a private nonprofit organization. Our governance structure includes a private public board. We have members of state government as well as large healthcare systems, providers, clinicians on our board that gives us excellent support and excellent guidance on moving forward through the evolution of HIE in the state. Being the state designated entity, that means that we were provided the initial infrastructure funding from the Office of the National Coordinator to build a statewide network so that we can reach all corners of the state. And our platform is basically doing clinical document exchange through a query-based, bidirectional platform through, obviously, it's private and a secure network. We are currently onboarding large healthcare systems, private hospitals, critical access hospitals, and independent physician groups. So we have started our implementation. I'm going to go ahead and go to the next slide. With our first onboarding participants in February of this year with our large health systems. And we expected about a 5 to 6 month start on the implementation. And we do expect to go live with those initial health systems in the next 4 weeks. So we're really on target for that. Our technology platform is a record locator model where all of our participants store and house their own data. And then there's a query-based platform. So MHC sends out the query. We pull it in from all of our participants, provide a longitudinal patient record. So it's right there for the physician or at the point of care for any clinician to see. At that point, they can either consume it into their EMR or let the query go. And you can pull all or part of the query into your EMR. Our network is role-based access, so everywhere from your help desk, your registration to a full-blown clinician will have access that is based on their level of necessity. And our network is only to be used for clinical treatment purposes and public health reporting. So anything that falls under the HIPAA guidelines, anything that you're doing now essentially is what our network can be used for. The value of MHC and what we can provide is we are an economical platform. We are a private nonprofit, and we do have the support of our federal funding that allows us to be economical. Our platform is a real-time aggregated patient query. Sorry, I'm a little nervous right now for some reason, at the point of care. And the biggest reason that we get a lot of participants or potential participants calling us is we have to meet meaningful use, where we need to hit those targets. And so through our network, that's the biggest point of focus for our implementations right now, is getting our providers up and running so that they can meet stage 2 and then on to the stages as we go through. So what that means for you is we can do your public health reporting, immunization registries, syndromic surveillance. We'll be able to have access to all the Medicaid, public health, and mental health data. So we already are building those connections with into social services and into Department of Health to be able to do all of that. Anything that you can access in cyber access today is what you will be able to pull into our network, but more than just the claims data, you'll now have the clinical data to back it up. Additionally, we are working, as you may know, Missouri has 8 border states, and we are working with each of those states to provide that one-stop shop to be able to access the data from Illinois, from Kansas, from Arkansas, from Iowa, Nebraska, and all of the rest of them, to be able to, especially for our border cities and our border participants, be able to cross those borders and not have to have an integration point with every other hospital or lab or other healthcare providers that you need to be able to talk to. So the gist of it is an HIE and Missouri Health Connection allows you to reduce the number of points of integration into one, and we're able to provide connectivity for everyone. Just kind of some services in detail. We provide the EHR integration services. We've got disease management tools. You're going to have, as we know, it's not about just what you can pull down, but it's about push. Everybody wants to be notified, so we have great notification services, inpatient admissions, emergency room visits, discharges. We also have the ability to provide referral support so that you can see information and house provider information within our network so that you can keep those referrals managed within your own networks or in your own hospital systems or health systems. We also have secure messaging and disease registry, medical home, of course, public health reporting, and encounter history and medication history. Our platform does operate under an informed opt-out model, which means that all you have to do is inform the patient that you participate in the Missouri Health Connection, and if you have any objections to that, here's the information on how to opt out. MHC manages the opt-out if the patient does not want to participate. So we take the onus of a patient opting out off of you and put it on us. So in typical workflows, it would be whenever you're providing at registration or at the point of care, whenever you would take that intake demographic information, you could provide a notice about you participating in the Missouri Health Connection. Also, we are information sharing on the network includes, we're a federated model so that you guys get to keep and house your own information, and then again the query goes out and pulls it in. And we help you meet all the meaningful use requirements, again, for all the mandates that are coming through for health reform. So just to kind of tie it all together as the 2 points for today in value-based purchasing. As we go through the evolution of HIE, Health Information Exchanges offer solutions and technology tools for you to be able to pull together information, to aggregate information in a form that you can use and do reporting and outcomes measures and work on that quality, which obviously we're talking about today, is going to give you those incentives to be able to do payment reforms and purchasing. Whenever we talk about quality and reporting, you need the information. The information is key. So to hit on his point, what is the value of HIE? Well, it's the information, but it's then what you can do with it. And so when you have the access to the information that you can pull together through an HIE, you can see what's going on with your facility. You can see what's going on in with your organization. And then you can take that information, and it's yours, and you can make the changes necessary. So I think that that's sort of maybe the meat of what we could talk about on the panel today. And this is just a list of all of our current participants, and of course this includes all of their affiliated physician groups and facilities and critical access hospitals and such. So that's sort of a global view of Missouri Health Connection.
Thank you, Angela. Okay, Mike Dittemore. Let's see if I can bring you up.
Good morning. My name is Mike Dittemore. I'm with Lewis Clark Information Exchange. I'm the executive director, registered nurse, been in nursing since about 1984, and a paramedic as well. So I do have some healthcare background. LACIE, a little bit about LACIE. We're a 501c3 not-for-profit. We are based here in Kansas City, Missouri. We're provider-led. Currently, we have 4 physicians on our board of directors. That includes Dr. Greg Ator, who's our chair. You'll be hearing from him later today. Dr. Laura Fitzmaurice from Children's Mercy, Dr. Joe Boyce from Heartland Health, and Dr. David Neal from Cerner as a large healthcare provider. He is not on as a technical person. He's on as a large employer that provides us healthcare services to their employees. Cerner is our technology service provider. We conduct business and exchange in both Missouri and Kansas. We're one of the 2 licensed or approved HIOs in the state of Kansas, and we also do business in Missouri. So we actually have no qualms with the state boundaries. We go back and forth all the time, and so that's why you'll notice in our name it doesn't have a state, because we don't believe in boundaries with that. We've been exchanging data more than 3 years, actively exchanging. We have right now with University of Kansas Hospital and Shawnee Mission Medical Center both going live with us about 3 weeks ago, 2.5 weeks ago. We have about 1.75 million records available in our system as of right now that are live and available to be queried. We can embed into essentially any nationally certified EMR so that a provider does not have to jump from the EMR to a portal back to the EMR. Dr. Ketcherside corrected me earlier today when we were having a discussion about this. I said, you know, we've got a group that a hospital that has Epic. We can embed into Epic. We did at KU, but they chose to have a portal, and their usage on their portal is about 1/20th of what a similar size facility's usage is being embedded to the EMR, because the physicians, the providers don't like to jump in and jump out back and forth. And they've got some of the richest data. They're smack dab in the middle of this 3 years of exchange. They're a wonderful use case, but they don't. The providers just don't like the portal when they have an EMR. All of our data that we get is sent to us, is stored at Cerner in redundant servers. We are a hybrid. We can do federated or we can do centralized model, either one. Doesn't make any difference. KU, Shawnee Mission, and KCMPA will all be federated. Children's Mercy, Olathe, Heartland, Truman are all going to be centralized sending this data. North Kansas City as well is going to be centralized, and then all the other clinics that we have signed up in the area. We have a deep, robust data in the greater Kansas City area and beyond. To give everybody here just a little heads up, you'll probably be seeing a little bit more about this in the next couple of weeks. We signed the paperwork this week. We will be connecting to the Tiger Institute, which is another HIO in the state of Missouri, and SmartNet, which is the HIO for the state of Oklahoma. Got a lot of press. They covered the hospital that was in Moore, Oklahoma, that was hit. That was SmartNet that they were connected to. We will be up and live with both of those before the end of the summer. We're already connected in CERT environment. We have been connected for about probably 2-3 months, but in order to go to the production testing, we have to get our data use agreements. The DERSA signed, and I signed mine last Friday. SmartNet signed theirs yesterday, and Tiger will sign theirs before the end of this week. Images, we are linking images into radiology reports, so CMIO radiology, so now a provider can go in, if that image is available in LACIE or one of our partners, they will be able to click on a hyperlink within the report and see the actual image. It will actually come to them. Our next phases are we'll start doing more to push images even proactively, but that's one of the things that will be up and live before the end of this year. We've already entered into that agreement. This is just a quick look at, not a great picture. If you'd like, I've got a booth in the next door. Please come by. I've got some screenshots. You can see what this actually looks like, because this is aggregated data. You don't have to go in and click on a bunch of different icons and stuff to pull data up. This is actually a example of how people are sending data to us right now. This happens to be Heartland Health in St. Joe. We can receive data either real time or nightly extract, depending on what the organization wants to do, so we don't put a strain on their system. So some of the things were sent real time, and when I mean by real time, that's when it's verified and signed off on. We don't take preliminary reports, we don't take preliminary lab results, but once those things are signed off on to us, they are sent to us immediately. The other things, once they're signed off on and they're formalized, they come to us in a nightly extract type of fashion. Really, this gets to the to the question about what is the value that HIO brings, and who do you work with. Right now we have hospitals, we have independent providers, we have clinics, we have ambulatory care centers. We have, in the last 3 weeks, we've had 4 payers reach out to us. In Kansas, the Medicaid payers are required to connect to an HIO, and so they are very interested in connecting with us to meet their requirements, and as well as KHIN. We actually have home health care, long-term care organizations, employers that provide care, such as Cerner. We have a pharmacy on board and others that have showed interest. And one of the other things we're looking at now is correctional facilities as well. That tends to be a big one, and that's where a lot of our tax dollars go. So if we can help keep care costs down there, that will help all of us. So what is the value that we bring? Reducing costs, decrease redundant tests, especially as we move for pay for performance from fee for service. You know, in the past, a CFO might say, I like doing those double, triple MRIs on a patient. That's revenue for me. Well, as we move away from that, that's not going to be quite the case. Assist in the reduction of readmissions is another area that we believe strongly we can help in. And then we have the deep data for analytics that we're going to have, especially with our centralized repository with the folks feeding centrally. We're going to have that data, and we'll be able to do analytics on their behalf as they request it. We also are working with some of our federated folks who are sending it to us federated. They may be interested in sending ADTs to us in the future, so that even though they're federated, we'll get some of that information through an ADT feed. And then efficiency, reduce time and effort locating the records, embed access to the HIO within the native EMR is huge, and data to facilitate transition of care. Just talked to a dentist a couple weeks ago, and he spends, or his staff spends, probably an excess of 4 hours a week on being on the phone trying to get records for a patient that has had a heart valve replacement to see if they've been on antibiotic prophylactically prior to doing any type of dental work. And the patients very seldom come in with records. They very seldom come in with any type of proof, and so they have to spend their time on the phone. It's a huge cost and a huge burden for them, and it's a wonderful case study for the use of the HIO. And I think that is, and I think it's right about 5 minutes. So, and this is our website. Please don't look at it for another couple weeks because it's undergoing construction right now. So.
Thank you, Mike. Okay, next we have Michelle McGuire with KHIN.
Hello, I'm Michelle McGuire from KHIN, and pleased to be here to talk with you about KHIN Health Exchange. Oh, sorry, I don't talk very loud. I have here for a list for you of all the sites that are live in KHIN so far. We have 43 different entities that are live, and that represents hundreds of locations because some of the hospitals bring on multiple locations with clinics with them. So you'll see we have a combination of hospitals, clinics, federally qualified health centers. These are all live with KHIN now, sending data. Here's another way of looking at it. This is a map that shows you the different kinds of data that we're receiving from community health centers, mental health centers, hospice, long-term care, hospitals, pharmacies, clinics, all spread throughout the state. These are the people that have signed intent to go with KHIN. And then this map shows you who is actually live, who is actually already live and sending data. And it's small enough that you can't see all the detail, but the point really is to see that it's all across the state and that we do have a lot of entities that are live already. The question was, how can we be of help? One thing that we can do is help you with your public health measures to be able to meet those for your meaningful use too. For example, immunizations. We are already live with immunizations. Hospitals send us the data. We pass it on to WebIZ, the state of Kansas immunization registry. It's kind of a win-win for everybody. It allows the hospital to just send it to us, and then we have to do the work to pass it on to WebIZ, and it's a win for WebIZ too, so that they don't have to connect with, many different hospitals and clinics across the state. So that's already working, and we've sent, thousands and thousands of records to them. Another thing is syndromic surveillance, and this also we're already live and working with. So we get the information on the diagnosis codes, and we pass those on de-identified to the state agency, and then they are able to do their syndromic surveillance. So we're live and working with that. We are in the process of working with a pilot site to be able to send electronic lab data. To be able to do that, we have to have a site that is using LOINC codes already and is doing reportable labs and is ready with both of those to send them. So we're working with a pilot site on that, but that one's in the process. Another thing that we can be of value with is a patient health record. We recently signed a contract with a company called No More Clipboard, and in Kansas it's going to be a requirement for being a HIE in the state to provide a patient health record to your patient. So many of the things that Martie was talking about this morning, as far as patient engagement and getting your patients involved and letting them have access to their information, will be something that we'll be able to help you do through the No More Clipboard option. So patients will have communications between them and their providers. No More Clipboard can deconstruct a CCD so the information can be placed in easy to look at lists of information like your medications, your diagnosis codes. The patients will be able to view, download, and transmit to help them with a meaningful use to measure, and patients can add information to this patient health record as well. And we're going to put patient education information on that to also help with that meaningful use measure. Patients view through any web-enabled device or mobile phones, so it'll make it really accessible to patients to be able to look at their information and to be able to track and graph their health measures. And emergency access to records for patients, so if they are visiting somebody else out of state and end up in the hospital, that they could pull up their health records and share it with that doctor. This next information is about being able to have how you count the numbers for if you're a hospital and you're trying to prove access to how many people actually use the portal. This information is on the slides to get your 5%. If you are a shared group of hospitals that are sharing a portal, if you're sending information up to that patient health record for your patient, anytime that patient logs on to the portal to look at that information, it counts towards your 5%. So even if they didn't look at your information that time, but they logged in and looked at some information, and you had sent information on that patient to the portal, then you get to count them. Sorry, I ended up. Also wanted to talk really quickly about some use case examples. For example, let's say a patient is seen at Kansas University and the patient returns home and then is ended up being admitted to Hutchinson Regional Medical Center. One of the ways that KHIN can help you with that is an easier way for clinical providers to find information about recent hospital stays on that patient. So when the patient ends up at the second hospital, they can access some information that was from that first hospital that they may have been harder to get or taken longer to get a hold of before you had HIE. Another example is a trauma patient is seen at Hayes, which is a level 3 trauma hospital, and then transferred to KU, which is a level 1 trauma hospital. The HIE can help you with the patient medical information is available at those hospitals so that they can see the information. I was out training at a hospital yesterday and had the director of nursing and the nursing, the head of nursing from the clinic, and they were both sitting in front of me when I was training. I got them into live, and they looked up a patient record, and the one nurse said, "Wow!" And I thought to myself, how much work and effort and years has it taken to get that wow? It was nice. Again, my name is Michelle McGuire. I'm not sure if I went 5 whole minutes, but thank you very much for your time.
Okay, thank you, Michelle. Now we'll get started with the HIE panel, and Paul is going to moderate this part, so I'll let him get started.
So I'll do my best to spur some questions here. But as you all can tell, we're in the unique situation as a border city with Kansas City, as is St. Louis, and there's many other cities around the country as well. But we have 3 different organizations that provide similar health information exchange services, but as you can tell from their presentations and short introductions, each of them have a different focus. So this is why HIMSS, our chapter here, decided to bring these folks together. Is okay, so let's talk a little bit about the value that each of these groups bring, and should we be joining one? Should we be joining more than one? How do they interrelate, and those kinds of things. So the first question I'm going to pose, but then I really would love to have some interaction with the rest of the audience here and the questions that you might have. But the first question here is, one type of health information exchange that we haven't talked about on this panel so far is actually those that are part of an enterprise or a health system, connecting their affiliated and employed physicians. What do you guys see the roles for enterprise HIEs, and how can they complement or work with your community HIEs? So just because you're closest to me, we'll start with you.
Okay. Well, I think that from Missouri Health Connection standpoint, we're already working to connect enterprise HIEs in the sense that with our 3 largest health systems, you know, as a large health system, they consider themselves to be internally a regional health information organization almost. And so the value is we eliminate the multiple points of integration. And so by doing that, you then have extra additional revenue to put somewhere else where you greatly need it right now. And then we are able to connect you to the community because we work with the other community partners and your other community referral network to get them on board as well. So I think the short answer is if you can do it in one connection, that's the benefit of instead of having to have multiple.
Yeah, Paul, that's a great question. Actually, Shawnee Mission Medical Center is part of Adventist Health System. As you know, they have more than 50 hospitals throughout the United States and 300 or 400 clinics, I believe. And with that, we have connected to them, and so we are connecting to that integrated health system. What we have done, though, with Adventist is to wall off the data right now that comes into the community. So we're just getting Shawnee Mission so we don't get overload if you've got matches from all these other states and all these other places this individual may have sought care instead of right here in the local community. The other thing is with KU, which has joined both LACIE and KHIN. KU basically is an integrated delivery system as well. Now they're on Epic, so that's basically connected themselves well internally, but connecting to them has allowed them to get out into the community more broadly as well. And then finally, what we have done is we have proposals together to work with Cerner and Certify. So if you have an organization that has, say, an EMR for their emergency room, another EMR for their providers, another EMR for the acute care hospital, we can actually work with Certify to integrate those into one connection and then get that out to the community. So.
Thank you. I think mine is some of the same. We also have KU live with us, and KU and Stormont Vale, both on Epic, were able to share information within themselves, and so now it's into KHIN, into the bigger. We also have the WE, which is part of KHIN, which is the hospitals in the Wichita area, and they're integrated into KHIN. And along with what Mike said, you know, it's surprising when you see that places that are part of the same, you know, a clinic and a hospital may be right across the street or even in the same building on different softwares that can't look at each other's data. So there's kind of some solutions, big and small, going on.
Well, we actually, as a certified business, really only provide enterprise HIEs. We've not really played in the state or the public sector, so to speak. And the value that our health systems see, and we have, David can keep me honest here, but we have probably over 100. Some are very large, like the Adventist health systems across multiple states. We have Advocate in Chicago. What they tell us, the reason they'll invest in these systems is because one is a tighter relationship with their physicians. Kind of goes back to HIE version 1, I guess. The other is because they might have an outpatient lab business and they really need to get a very tight orders workflow going. And so I don't see them necessarily as the same thing. What I think is going to happen is that the enterprise HIE will probably morph a lot more to an ACO platform. as opposed to a generic health information exchange. But I think there's a place for both of them, and we just need to make sure that we all connect, which we are.
Any questions from the audience? Joe?
I got a question. Several of you mentioned connecting to adjoining states, but somewhere in the dregs of my memory is a nationwide health information network and a NWIN Connect and some other standards around being able to communicate more broadly. I mean, I would hate to think we've taken a bunch of small silos and put them in slightly larger silos that are still silos. I'd like to think that when I'm in Memphis and I trip and fall down on Beale Street and the doctor can connect to the Mid-South eHealth Alliance and be able to connect through some mechanism to get my record up here. Are any of you looking at NWIN Connect or broader things? Could you speak to that?
Actually, it's eHealth Exchange now. Is what it's called. And
I said it was dregs.
and yes, we are looking at that. Actually, Cerner has once the CHIT comes out with the standards to be a certified HIO platform, Cerner has stated now that they are going to get that certification, and then we'll look at connecting them. I will tell you right now that they tend to be the federal connection point with DoD, VA, SSI, but their connections, the quality of queries and being connected on those queries is very, very low right now. They use very limited data points to query, and I will tell you, I think they're somewhere in the, this is just an estimate, so please don't hold this on and granted or write it down, but I think it's somewhere around 30–40% as accuracy on their hits they're getting back right now. Now that's going to improve, but it's not great right now. And so when a provider goes out and does a bunch of well taps and they're dry, they're not going to use it. So we're kind of waiting until that gets a little better, and then we'll go forward with it. Is our plan.
I can tell you that Missouri Health Connection, we're in process of becoming members to eHealth Connect right now, and it's being the state designated sort of that's the way that the HITECH Act kind of envisions it, so that everyone would come through and we'd able, so that when you fall down on Beale Street, you will be able to pull it down. And Mike is right. As soon as this evolves more, it will be more successful of a connection point, but the value will grow over time, certainly. And both of all three of our 4 of our organizations are probably definitely clearly interested in being members long term.
KHIN is working as well to connect to other states, and then also I think that personal health record will be very helpful if you find yourself out of the state and need to access your information.
Congratulations on that.
Thank you.
I came in late, so you may have already covered this, but one of the things I'd be curious to know your thought of, how many different networks are being established? Is data being replicated in all of these places? And therefore, the cost of doing that in each of your networks, because you have referenced multiple of you collect data from the same places. What do you see the future? Are you going to just have metadata records so you know to go get, or actually replicating data in each of your systems?
Well, right now, there's not a lot of overlap right at this moment. Like, for example, we're both, KU is connected to both of us, but that's about the only example we have right now of re-replicating that. I think what the big question is it gets down to sustainability. How are you going to sustain yourselves, and how are you going to be around to share that data down the road? So I think all of us have different sustainability models on how we're planning to do that. We were very fortunate in that Heartland Health started this out about 5 years ago, and they donated it to the greater Kansas City community, so we don't have any debt, which is a nice thing not to have. And then we did receive grant money through Kansas, because Kansas does not have a state-designated HIO. They provided applications to both LACIE and KHIN, and we both were approved HIOs in the state of Kansas. So we both have drawn down ONC money from the state of Kansas, but there is no single approved HIO in Kansas. So I think that down the road, right now, I think there's around 60-some active HIOs in the United States. I think just as we're going to see critical access hospitals start to go away in the next few years for funding, I think you're going to start to see HIOs start to merge together. And if the Commonwealth initiative that Cerner and Allscripts and McKesson and some of those are going after to work together, if that comes together, the HIOs won't look anything like they are now. They'll be more in data analytics and things like that if they're even still around. But I think that's going to be 10 years from now or so.
So what's the financial model today?
For LACIE, it is our members pay fees, and that's what we base our sustainability on.
Based on use, based on
No, we don't want it based on use because we don't want to penalize anybody. We want them to use it. So what we do is we're based on size. So if we do staff beds, and then we do, if you are a provider, we actually do group purchasing as well. For example, KCMPA has a sliding scale. So the more physicians they have come on board, it drops their cost per provider down. And then I think it's maxed out at 200 providers, and so anything over 200 stays the same cost, but we start out at 1 to 50 and then have sliding scales. And that's how we're doing it anyway.
KHIN also has participants pay fees, and then we had some O&C grant money for startup of technology costs.
Do you view lots of questions. Do you view when you move to a PHR model where in essence the patient is controlling and managing access, whatever, consolidation of the data, what do you think the financial model will be for that? Will I as a individual have an opportunity to pay to have my medical record resident somewhere, or will that be the provider organizations?
At this point with KHIN, we are not planning on charging the patients.
I think you may see the insurance companies want to get more involved with that piece of it right there. That's the payers. That's where we're seeing interest at now. The depth of data we're starting to see now and the relevancy of it, it's data that they would get anyway. It's just now we've taken the 90-day lag out of it and then get it real time. And so that's where the interest is starting to show. And I think that's a way that we'll be able to help some of these small organizations, small providers that can't afford to, even another $100 a month is a big deal to them. We'll be able to maybe offset those costs significantly through the payers.
And just to chime in here at the end, Missouri Health Connection does also charge its participants fees, and we do not anticipate charging patients in the future.
Mark with Humana, could you address any PHR activities?
Yeah, I think there's a ton of overlap at the moment, and we all have our own initiatives. Humana's view is, they have their own PHR effectively for all of their members, and they want to consume data, but there is a lot of overlap, and I don't know how to address that question except let it play out, and business models will prevail. But
We actually, and this may not be the politically correct thing to say, but we actually had no plans to do a patient portal because essentially all of our members have patient portals. But as Michelle mentioned earlier, to be an approved HIO in the state of Kansas, we are now required to do that. So that's a mandatory overlap, if you will. And so we will provide that. But we actually, our board really did not have any desire to do that. Because essentially all of our members already had it, so we're just reduplicating. And what I worry about when people go out and see that, let's say they have a question, you look out in your record, you're going through the HIO and it says that you have hypertension and you disagree with that. Who are you going to connect? You've got it through, you've just looked at it and you looked at it through the HIO, so are you going to connect it to the HIO and say, I'm not hypertensive, and then we're just going to have to redirect you right back to your provider or the hospital, where we put it.
Yeah, obviously the value is the aggregation of the data, which is many sources, not always even that of, say, a Humana, right?
Question in the back?
Your comment kind of made me think of a question. So obviously as patients get healthy and data changes, how do you guys ensure that if one person is seen at a facility and the issue no longer exists, how do you make sure that data gets back to all the other organizations so that when you do query the data, you're getting up-to-date information?
That's a great question. Actually, it comes in with the overlays. So when a new patient information is submitted in, so let's say that they no longer have that condition or what have you, then it would be, if that's been no longer applicable or they've taken off a med or what have you, when that new data comes in, it overlays the old data, and so it drops off the list.
But are you ensuring that all the people that you're querying from are updating their records so that when you query it again, it's not a mix of data?
Yes, that's part of the connection process and part of how when we do the connection initially and figure all of how we're going to do this. Is it going to be IHE standards? Is it going to be HL7? All these types of things. How is those updated records going to be put in there and overlaid? And same way with corrections. Somebody might document something that in error, and so they go in to correct it. How is that overlaid and done appropriately? So yes, that's part of the process.
A lot of the EMR vendors today, if they're getting certified for certainly stage 2 of meaningful use, they have to follow these IHE standards and create a repository, and so you can't stop human errors. But as the encounter is completed, they hit the enter, it will generate a record that gets put into the repository, and then what will happen is we send a request for the latest data, bring the data back, and then as we talked about, you can consolidate, you create a CDA, you do overlay it. So the first time you look at it, you might just see the current data, but then you can drill down, say, on medications or anything like that. But we have to push all of the vendors, and I'm real hot on this one, but we've got to push all the vendors to make sure that they do support these IHE standards, because our lives are so much more difficult if it's a transactional-based result like an HL7 message.
And additionally, I spoke about notifications and the need for push information. On our network, you'll be able to see if you queried a patient that if there had been information that was input inaccurately or a condition was changed, there will be a notification not only on the screen visible, but you can also subscribe to a patient or a physician or a condition, set up notifications within the network to be able to get updates such as any changes in care or conditions, so that you'll be able to have that information pushed to you as well.
Any other questions in the audience?
Information exchange is, as it's mostly been described here, not yours, but yours, has been predominantly transactional, focused around, I see a patient in the office today, I want to catch up on all their record. And there's huge value in that, no question. But as we move along from fee-for-service to value-based purchasing, providers in ACOs, Medicare Advantage programs, whatever they're in, have to have data not just transactionally on a single patient, but they have to be able to look across their population and manage it. Now, the Humana stuff is looking toward that. But in the architectures and in the plans that you've got, for example, in a federated model, I'm not aware of any way physically to do population health management, because you do not have a record of the patient. You dynamically create them and they disappear. And I don't think it's computationally feasible to dynamically create the records of your entire population and run analytics on it and then have it disappear. So as we move from the transactional model that we've got today toward where we're inevitably going of managing populations, can each of you talk about how you see your system evolving to support that? Or is your focus around being transactional and it's the provider system responsibility to build in that analytics tools, which, granted it's a smaller population, but if you're an ACL, I mean, if you're a Medicare Advantage Humana plan and if that's the bulk of your stuff, maybe that's all you care about. But can you guys address that from these large organizations? Do you see yourselves as, in the long run, supporting those population health management tools, or is there some other model?
Sure. So HIE is a lot of different things, and providing the network and just the infrastructure is basically just the foundation. So certainly we will have additional services, and analytics will be one of them, and it's because there's the value, and that's what you need. So our roadmap does absolutely include offering additional services to help you move towards the transition from fee-for-service to value-based, and certainly analytics is a huge part of that.
How will you accommodate that in a federated model?
Well, our platform is supported by InterSystems, which is our technical service provider, and they have great depth in the services that they can work with us to provide to set on top of the HIE and set on top of your EHR. So we have I couldn't probably get into the weeds of what all that entails, not being a technical person, but certainly that is in the future for us.
I knew when I saw you today, Dr. Ketchside, you were going to have hard questions. So. What we're looking at is a company called HMS, Health Metrics Services. There are several organizations here in town that are already using them. They are a huge analytical engine, if you will. They can slice and dice data. For example, A1Cs, they can look at it, because we talked about standards earlier. They can slice and dice it, so you're looking at under 7, over 10, different demographics with age, gender, what have you, different types of diabetes diagnosis. It's phenomenal. So we are working with them to have that as a very robust analytical potential for us. And what we would need to do from the federated, because we do have several that are federated, we would have to feed that information into them, and they would probably, what we've talked about, this is just high-level discussion, but they would attach their appliance, if you will, to the organization's EMR, to their database, and then they would be able to get the information so that we can have the information for the analytics. Because you're exactly right. Right now, population health, if it's federated, it's great for single. You can't do much with it.
It's a great transaction model, it just doesn't provide
No.
that.
So that's what we're looking at. We're actually HMS too. If we have a EMR vendor that's difficult to work with, we can actually attach to them and bypass the interface with the EMR vendor.
I think KHIN is some of both of those. Our vendor is ICA, and they are doing some analytical reporting, and then we're also, the board's actually meeting today, that's where Laura is, and looking at a contract for analytics vendor.
I was going to have a word with her for skipping out on this.
She wanted to be here.
She hasn't.
Other questions? Okay. Change gears a little bit. It was mentioned earlier that one of the values of the HIEs is reducing the number of connections with organizations. So, for instance, providers or private practice physicians now are connected to labs and to hospitals and the like. So, as we're talking about the evolving role of HIEs from being transactional to them providing business analytics, is that going to be a fee for service to the provider community, and the savings of multiple connections is going to allow them to do that? How do you guys feel providers are going to be able to pay for these additional services to be able to report on value-based quality initiatives and the like in order to maintain their payments currently?
What we think is that we actually are going to have proposals with some of the payers, and so the depth of information they'll be able to get will already be normalized and standardized when it's sent to them. It will be sent quicker than what they're getting it now, and so we think that is going to be a way to help offset some of those costs for the providers. We don't look to increase any charges for anyone, but find other ways of revenue to bring it in to keep those costs down. So right now, I would say, Paul, that's primarily we're looking at down the road for the payers to be engaged, and as right now, that looks very positive. It looks very, very good.
I would agree with that as well. We do not intend to increase the fee to that the providers are paying. Find other methods to cover the cost.
I think certainly we'll be engaging the payers as well. I think we sort of see it as a cost shift as well, in the sense that if we're eliminating your integration to Quest, and we're eliminating your integration to the state, and we're eliminating to all the radiologists and all the pathologists, then you have that ability to put that lump of money into something else that's even more valuable, into something like analytics or some sort of reporting system that's going to help you down the road. So I think MHC's approach is sort of a combination of both KHIN and LACIE, and then as well as is the cost shift model.
So Mark, this gets to your point earlier about maybe this is why EMR vendors hold the data so closely, is as they have fewer and fewer connections, their revenue stream is reducing. So how do you in the other HIEs intend to at least adapt to that new model that the EHR vendors have got to deal with?
There's a tremendous move on the whole discussion around big data, right? And so one of my beliefs is that the large EMR vendors are holding the data for that reason. They can monetize it. And that does create another layer of silos. That's an education thing. I think part of healthcare reform is to break the barriers, and I personally wouldn't select an EMR vendor that's not truly capable of sharing all of its information. And one of my roles in Humana now is to do EMR vendor selection, and that's one of our criterias. I mean, it's incredible. We're in an industry which is about the care of the human being, and the vendors that are playing it have a very different view at times, so it is a challenge. Humana's view is there's going to be some overlap here for sure that we just need to all figure out, because their view is they will go after their own members. They believe that the wellness information is just so important, and by the time the patient has checked into a hospital or an outpatient facility, it's sunk cost to them, and so they want to spend all their time. When I'm a consumer, they call them consumers, not patients. Or when I'm a consumer, that's where they want all their time, so spend all their time. So I think we'll end up connecting, but we'll spend most of our time up here trying to affect the way you guys all live your lives.
This is, just to echo some of this, I think the other piece to this is what we're defining as analytics too, because I think in our discussion I heard analytics, and I heard generating reports, which to me implies maybe a kind of a retrospective thought. But a lot of where I'm seeing analytics moving towards is the through blasting through real time, moving to predictive analytics. So my thinking is, do you have the infrastructure, the capabilities, and we talked about the transactional nature of getting the data to really provide the right type of benefits, or maybe are you thinking maybe you're a benchmarking capability or something, scoring and benchmarking within the region. But so I think it's a bigger nut to crack, frankly, and the pace in which the maturation of the need and demand for analytics is moving.
I'd like to echo. I think you're so right. So I think we all get very confused about analytics. So there's one concept which is get the data in, run a set of predefined rules against it, and get some outcomes and go do something. That's a gap in care. And then the other truly is predictive, which I don't think can live in any kind of HIE. I think that's about taking all of us and looking for connections, right? And there's a thing called the Bayesian Belief Network, which is a really interesting tool which would start gathering us together and start finding commonalities between us that aren't based on hair color or weight. And it will try and say, okay, Mark, you've been put in this group here because you're going to get congestive heart failure because these 5 people are just like you, and 5 years ago they had it, so you need to go sort yourself out, right? And so that's the ultimate dream. And this is why I think the EMR vendors are starting to try and hold the data, because that's where they see the play, right? And then they see insurance companies as really wanting it, and so there's a huge transaction model for that. So we're evolving very quickly. But the difference between rules and predictive is very, very important.
I think we're moving past the run a report, let me know that something bad happened in the past to give me the opportunity to impact the outcome.
Right. Yep.
One question I had when you were talking, Michelle, about the nurse that got the trauma transferred to her and looked and said, wow. Are you saying, would you set up different connections that allow different share of information? Or is that just from a CCD exchange that she said, wow? Or what, you know, where is that going?
She was looking at a CCD when it was her first time to look at the exchange, and I think the wow came from the fact that for her to get some lab, she was looking at some lab results. For her to get that lab results prior to that, she said she would have had to call over to the other hospital and wait, and the patient would have waited for, you know, at least an hour to get that information there, and now she could just pull it up. And she was the head of all the nurses at that clinic, so I think she could just see how it was going to, you know, make life easier for them to be able to just click a couple keys and get some information than have to call and ask for it to be faxed.
I just didn't know if maybe there was more that could be shared and you define it by different who your contracts with, or is it just that limited amount of data?
I think there's always more you can share. You know, the more information you could get in there, you know, Mike was talking about x-rays and stuff, the better that you can make it for them if they can see everything, and to get their whole record, you know, if they were seen at a couple different hospitals and some specialists and a primary care, to get that all in there, which is what we're headed towards. So I think the more, the better. But at least what she saw, she found very useful.
Any other questions? All right, we're pretty close. Okay. Couple of items here real quick. First off, let's thank our panel here for being with us today. Your name badges, if you would please, before you leave today, drop those name badges off. Obviously, you'd like to keep them on and keep you here as long as possible, but if you do leave early, where you registered, there is a box that you can drop them. Johnson County Community College provided those for us today, and we'd like to return that material. Lunch is being provided next door. I think we have 1 hour. Plenty of time to discuss one-on-one with our panelists and some of the presenters. Also, please take some time to visit with our sponsors and their tables, and I think our HIEs also have tables over there as well. But we look to have you back here at 1 o'clock, and we'll start our next presentation at 1 o'clock, I think, is actually on the analytics. So looking forward to that. Thank you.